Hello, and welcome to the 2024 George H. Rawls, MD, Memorial Lecture on the History of Minorities in Medicine. We are here today to honor the memory and celebrate the work of Dr. George H. Rawls, a man who truly was a pioneer for Black surgeons in the Indianapolis community and who spent his entire career and retirement advancing minority representation in the medical field. Dr. Rawls graduated valedictorian from Florida A&M University, where he earned his Bachelor of Science in Biology. He then attended Howard University Medical School, where he earned his medical degree with Alpha Omega Alpha honors. He served in the U.S. Army for 2 years and completed his surgical residency at Ohio State University and a surgical internship at Philadelphia General Hospital. In 1959, Dr. Rawls began his practice as a surgeon in Indianapolis, and after a distinguished 34-year career, he was appointed Assistant Dean of Student Affairs and Clinical Professor of Surgery at IU School of Medicine. Dr. Rawls helped launch the Master of Science in Medical Science program in 1995 to support students from underrepresented populations in medicine. As of 2020, the MS Pipeline program had graduated 469 students, with over 300 matriculating into medical school. In 2001, Indiana University awarded Dr. Rawls an honorary Doctor of Science degree to recognize his enduring efforts to increase representation of minorities in the medical profession. A devoted student of history, Dr. Rawls' most important contribution from our perspective was perhaps his History of the Black Physician in Indianapolis, 1870 to 2000. Dr. Rawls passed away in 2020, and later that year, the Indiana Medical History Museum established this annual lecture series to honor his memory and recognize his many important accomplishments, as well as to tell the story of medicine as it relates to minorities and underrepresented and underserved groups, whose voices and stories are frequently left out of histories and of the historical record. Our goal with this series is to highlight the vast and varied ways that minorities have both participated in and experienced medicine. These rich and important stories have been too often overlooked or ignored, missing great triumphs of invention and discovery, as well as heartbreaking incidents of racism. Our speaker today is Caitlin Downey. Caitlin Downey earned her MA in History at Indiana University. Her master's thesis from 2020 was titled Gendered and Racialized Experiences at Central State Hospital, Indianapolis, 1877 to 1910.
Thank you all for coming today. I'm here to talk to you about my master's capstone, which was entitled Gendered and Racialized Experiences at Central State Hospital, 1877 to 1910. So I first learned about Central State Hospital at Admitted Student Day for students admitted to what is now IU Indianapolis. And I don't remember how the faculty got on the topic exactly, but someone mentioned Central State Hospital, and I knew instantly that one, I was going to accept and attend this program, and two, I was going to complete my capstone on the treatment of Black patients at this hospital from Reconstruction to the end of what is called the nadir. So broadly 1870 until 1929. That was my area of interest. And as I began my research, I realized there was a need for this type of scholarship. There was a real dearth of information regarding African-American asylum patients as a whole, but especially outside of the American South, which does make some sense, as the South was where there were the largest populations of Black patients, as well as fully segregated hospitals. And I think historians have yet to really extensively analyze the experiences of Black patients in Northern institutions, even in Northern cities that have larger Black populations than Indies like Chicago or Detroit. My work was informed by 4 guiding questions. First and foremost, what was life like for African-American patients at a majority white institution that initially did not want to receive them? Second, how did institutionalized racism affect the treatment of African American patients day to day, and also the outcome of that treatment? Similarly, how did institutionalized sexism affect female patients' treatment and its outcomes? And lastly, how did race and gender intersect? And I attempted to answer these questions through three methods. The first was the story of one patient, Elizabeth Furness. Second was a more qualitative analysis of the information in the hospital's annual reports. At the end of each fiscal year, the hospital would submit an annual report to the Indiana legislature. And lastly, I undertook some statistical studies of, albeit limited, patient data. I began my research with the Indiana Archives and Records Administration's digital archives. At the time, the Archives and Records Administration had transcriptions of hospital admission records for patients admitted between about the 1850s and 1920s. So I searched for the keyword colored, which was the accepted terminology at the time. And this returned about 172 patients between 1877 and 1904. It was 138 men and 30 women. And so to create a white patient pool for comparison, I searched for 4 keywords, and those were mania, melancholia, paranoia, and heredity. And I chose 172 names from among the results. And the digital archives were set up in such a way where I couldn't get all results by searching for like a punctuation mark or an article like a, an, or the. I had to include some type of keyword. And I noticed that those 4 terms appeared pretty frequently. And these transcriptions contained, in general, the patient's name, their ID number, admission date, diagnosis, the county they were admitted from, and it indicated whether or not they were buried on hospital grounds. And it did have some limited information related to their condition and the circumstances of admission. And some patients would have a whole paragraph, others would only have a sentence or 2. And my white patient sample contained about 114 men and 54 women. Fairly early on into my research, I ran into some significant roadblocks. 3 months in October 2019, the Archives and Records Administration took the admission records down as they were technically in violation of Indiana HIPAA laws by having those available online. Similarly, due to HIPAA laws, I could not access patients' records, not their charts, not an autopsy if one was performed. So to try to pad out this limited info from the admissions records, I searched for patients' names in historical newspapers, the hospital's annual reports, as I mentioned, and genealogical records like birth, death, censuses, and marriage records. And one patient stood out to me as I was reading through the admission records for Black patients, and her name was Elizabeth Furness. Tomorrow will be her 176th birthday. She was born in September 1848 to parents John Jackson and Carolyn Frances Ross. She married William Furness in 1867. The couple had 2 children, Henry and Sumner. They moved to Indianapolis from Lee City, Missouri, where William taught math at the Lincoln Institute. So they moved here in 1880. Both Elizabeth and William were school teachers. Elizabeth taught at Indianapolis Public Schools number 19 and 24, and William taught at number 24 as well, and also served on the school board. Elizabeth was first admitted to the hospital in June of 1889. Her admission record noted that she had suffered from mental illness for some time. Her symptoms included delusions, paranoia, and even suicide attempts. Her physician diagnosed her with periodical insanity stemming from menstrual trouble. And she left the hospital on furlough in the spring of 1890. And that phrase stood out to me, menstrual trouble. Because on the face of it, this seemed like a diagnosis we would expect to see for a middle or upper class white woman admitted to the hospital during this time, or at least popular conceptions of women admitted to institutions like Central State at this time. So I wanted to know how Elizabeth's diagnosis fit into the larger context of female patients' experiences at the hospital during the Progressive Era. Did the hospital staff really believe that there was a link between reproductive illnesses in their female patients and mental illness? So to do this, I analyzed the stated causes of insanity for 5,420 female patients admitted to the hospital over a 20-year period between 1885 and 1905. And these were enumerated in those annual reports. The reports would include a table of how many patients were admitted per month and what their estimated cause of insanity was. So I divided these into 4 broad categories: reproductive, situational, non-reproductive medical, and unknown was its own category. So during this time, about 10% of the women admitted to Central State Hospital had a reproductive condition of some kind named as the underlying cause of mental illness, compared to about 53% situational and about 39% medical. So did hospital staff really believe that there was some kind of link between reproductive illness and mental illness? Yes and no. In general, among 19th century physicians, this was more common among obstetricians and gynecologists than other specialties because, well, when you have a hammer, everything looks like a nail. So, asylum psychiatrist, what I saw multiple times was, although the link between reproductive and mental illness could not be definitively established, there was a link. And the hospital was going to divert some of its, albeit limited, resources to trying to uncover and resolve this issue. For example, in the annual report for the 1882-1883 fiscal year, Superintendent William B. Fletcher noted that a large number, perhaps the majority, of applications for female patients had the cause of their mental illness attributed to diseases peculiar to their sex, either by the physician who examined them or a court-appointed medical examiner. Whether this was definitively true was difficult to determine, but the hospital persisted with this thinking anyway. The hospital hired its first female physician, Dr. Sarah Stockton, in 1883, partially for this reason. Part of her duties included performing pelvic exams on female patients, and she was hired for both the patient's comfort and the comfort of their families, knowing that there would be a woman on staff who could address this issue. So what was the purpose of linking reproductive and mental illness? Like what was the point? Well, I would argue that there was a more insidious reason behind this beyond just mere lack of medical knowledge that we have today. And that was attributing mental illness to a reproductive illness turned it from something that could potentially be alleviated into something fixed and unchanging. To many 19th century scientists and physicians, the gender you were given at birth determined the course of your life, your personality, who you were, what you could do. Sex, much like race, was a biological determinant that could not be overcome. And if women, especially white middle and upper class women, were so fragile that the smallest upset to their reproductive system could send them spiraling into insanity, they then, therefore, should not be allowed greater social and economic mobility, civil rights, and access to education. And women of color were largely missing from this whole debate on the link between mental and reproductive illnesses. Prior to the Civil War, white medical men's interest in Black women's bodies was unfortunately limited to productive and reproductive labor and sexual gratification. Now that we can no longer import enslaved people from Africa, how do we make more? After the Civil War, the focus then shifted to how do we limit Black women's reproduction? As thousands of formerly enslaved people left the South for the North, they were threatening to become almost a kind of public nuisance, overburdening the public benefits system and encroaching on white communities. Given what we know about the probable purpose of linking mental and reproductive illnesses, then Elizabeth's diagnosis stood out all the more. And I believe her class privilege appears to have afforded her this diagnosis during her first hospitalization, but not her second. And gender differences at Central State Hospital were not just limited to diagnoses, it also included treatment. A statement in the 1869-1870 hospital annual report noted that male patients were moved out of what was called the basement and into a new wing of the hospital. And the basement was low, narrow, dark, damp, unventilated, difficult to warm, prison-like, and forbidding, unfit for the habitation of human beings. It was originally meant to house male patients who were at risk of suicide by hanging. However, female patients were kept there due to hospital overcrowding after the male patients were moved to that new north wing, and it would remain occupied until about 1885 when the hospital expanded and a new wing opened up for women. Behavioral therapy for female patients included feminine leisure activities, reading, handicrafts, low-impact exercise. The hospital introduced a new educational program for its female patients in 1885, and patients in this program knitted, crocheted, sewed, played music, made paper flowers and lace. Most of the items that they made through this program were sold, and the money was used to offset the cost of their treatment. The program planned to add some basic literacy courses for women, but these were conveniently unavailable or would be deferred for unknown reasons. The hospital opened a similar program for its male patients a year later, 1886, and this program focused on education and more intensive exercise, with the idea being that the male patients will use this educational knowledge more. Our female patients don't really need it as much. And although hospital leadership swore up and down that patient labor was not used for the hospital's financial gain, it was. It was very expensive to house and treat so many people. So patients that would work at the hospital, the men farmed, did landscaping work, renovation and construction on the facility buildings, and carpentry, while women sewed and knitted clothes for their fellow patients and canned and preserved produce grown in the hospital garden. Financial statements in the hospital's annual reports during Elizabeth Furness's second institutionalization showed that she did earn money, or it was put forward from the sale of clothing that she made during her second stay. By the time Elizabeth was hospitalized for the second time in 1893, her institutionalization appeared to more closely match those of the other Black patients that were hospitalized during this time. The admission record for her second institutionalization noted similar symptoms to those of the first. She was experiencing paranoia, had trouble sleeping, was irritable, and was reportedly abusive to her family. Sadly, Elizabeth would remain at Central State until her death in November 1909. She is buried at Crown Hill Cemetery next to her husband, William, and her son, Sumner. So the hospital, as you may know, opened its doors in 1848. And Central State initially did not admit African-American patients, as the African-American people were technically not considered Indiana citizens. The first African-American patient, likely a woman named Mary Gaskin, was admitted in 1854. And African-American patients were not admitted with any real regularity until the 1880s. And by the time the hospital started seeing Black patients in regular numbers, scientific racism had firmly taken hold of American science, medicine, and psychiatry. For the purposes of this talk today, I'm going to define scientific racism as the idea that there is a natural, fixed racial hierarchy to human beings. Races have distinct biological differences that can be empirically proven through the application of scientific methods and principles. Sitting at the top of this hierarchy are white Anglo-Saxon Europeans, and at the bottom are African Americans. Too many 19th century scientists and physicians, African Americans existed in a kind of evolutionary arrested development. They had ceased to evolve thousands of years ago, leaving them with underdeveloped brains, childlike personalities, and as a result of both, a propensity towards alcoholism, drug use, and poverty, as well as lower rates of depression, as depression was the intellectual's disease. So what did the data show from those admissions records that I gleaned from the Archives and Records Administration's digital archives? Well, based on my studies of albeit limited patient information, if you work with statistics for a living, I'm sorry, the average length of stay for Black patients compared to white patients was 3 versus 2.7 years. Black patients were about 17% more likely to be diagnosed with mania than white patients, reflecting that assumption that depression was a white person's illness. Black patients were also about 36% more likely to die at central state than white patients, although there were likely other factors contributing to this. A lack of access to adequate health care in Indianapolis, symptoms of physical illnesses manifesting as psychological disturbance, and poor living conditions at the hospital for patients of all races. White patients also appeared to have higher recovery rates than Black patients did, based on how many white patients' records would have recovered or improved noted in that admission record versus Black patients. I have some charts here of differences in diagnoses by race, treatment outcome, and recovery. So what does this tell us? Well, medical racism and gender discrimination have not gone anywhere. Ladies, non-binary folk, how many of us have gone to the doctor only for them to be dismissive or just outright rude? African American patients today are overall less likely to be diagnosed with depression and other mood disorders compared to white patients. African American patients are also more likely to be diagnosed with schizophrenia than white patients. And both of these diagnostic disparities occur even when controlling for symptom severity and patient functioning level. African American patients are less likely to be prescribed psychiatric medications, and when they are, the medications given to them are frequently incorrect, ineffective, or outdated. Ineffective treatments and a lack of cultural awareness or understanding up to and including mistreatment also contribute to current disparities in mental health care for Black patients, especially Black women. So what does Elizabeth's story teach us? I think her story highlights the importance of intersectionality. Parts of our identities don't exist in a vacuum. We are not just white, just a woman, just disabled. And we will not fully understand the story of Central State and other hospitals like it until we consider intersectional patient experiences, just the battle cry of every beleaguered historian. We're not going to learn from this unless we study our past mistakes and work to correct that. That's all I have.